pressure, and that's another reason why we don't like doing stuff. Oh shit, 4-year-old, pre-catheter, you can split it and things like that. So just that pressure of the dye has somehow moved that flap that you saw there and blocked it off. And if we hadn't done an angiogram, because she had ongoing chest pain, she sort of didn't get better. She sort of got better, and then she still had ongoing chest pain and ECG changes. So something is going to happen if we don't do anything. Thrombolysis probably not going to make it worse. Probably not going to make it better. Might make it worse because it might make you bleed more. So if you've got an expansive flap, or you've got a tear in the wall of the artery, will bleed more into it. And that's one of the reasons there's a bit of debate about giving dual antiplatelets for it as well. But I think first of all, it's good. If it's open, keep it thin, keep the blood thin until it's healed up, until it naturally heals there. Yes, behind.
I don't know whether you have a retrospectoscope in your department, but knowing that story, you must have thought that there was a risk of dissection. Why did you choose to go in the radial artery rather than the an inguinal vessel to start with?
Well, that wouldn't usually make a difference. Like the spasm is, because she's only a really small woman, she's like about 45 kilos, or 50, she's a very small person. If you can go radial, your complication rate is lower, your mortality is better. So we always do. I'm a radial operator, I do pretty much everything I can radial, unless you need to put in really big stents or complex procedures, and then we'll go femoral. And you can also cause problems, you can cause dissections. If they've got vascular fragility, you can mess up their inguinal. So the radial dual supply to your hand is kind of a safer option. Yeah.
Can you see them on less invasive imaging?
No, so she'd had a CT scan that was reported as normal. Because it's a flap, you get contrast from both sides of the flap. They often can't see them. So they often will think they look normal on a CT scan. So she had the other thing about her CT scan, they did because they were worried about, did she have an aortic dissection? So it's not a gated scan. So the CT coronary angiogram is a gated scan where they're looking at the heart in between heartbeats. So that has a better chance of seeing it. Okay. So I'll show, I've got to remember who this is now. Oh yeah, I remember this guy. This is only from a few weeks ago. This is a 39-year-old Indigenous dude. He came into ED on meth, intoxicated, off his chops. ED couldn't manage him. They sedated him. He'd been asleep in the department for a couple of hours. And they noticed that his ECG had been sort of changing while he was there. So he'd actually had bypass surgery December, so 3.5 years before. And so he'd had some sedation about 4:30 in the morning. I don't know what I've done a typo there. And his ECG initially was pretty unremarkable. He's got a tachycardia because he's probably related to the meth. So 7:30 in the morning, they called me because he had this marked change in his ECG on the monitor. So they did a 12 lead, and he was still asleep. And they said, "Oh, what do we do about this?" And I said, "Oh, let's get out the story." I said, "Give him dual antiplatelets, give him a spray of GTN, might be spasm." And they called me back and went, "Oh, it's all gone away. It's all resolved. He's still asleep. His ECG is back to normal." So we gave him dual antiplatelets and thought, has he got because he's had the meth, he can be a vasoconstrictor. Has he just got coronary spasm? Knowing that he's also had ischemic heart disease. You can see there, it's all resolved. So we gave him what we'd normally give an acute coronary syndrome. Then I got a call from the day reg when they'd handed over about, this is about 5 minutes past 8. He woke up with a bang, that's what she said to me. He was agitated, he had severe chest pain, they resedated him, and then he had a VF arrest. So they they shocked him, and he had another. He went to silence briefly, and then had a VF arrest again. And the second time, you know, though he was down for a while, he ended up getting intubated, and his ECG, STs were up again. So we brought him to the Cathlab. What do you reckon? Spasm? Arms up? Hands up? Spasm? Coronary disease? Coronary disease and spasm? So he's definitely got, we know he's got coronary disease because he's had bypass surgery. Unless he's had bypass surgery for spasm before, which sometimes happens. So this is his angiogram in 2022. So he's got a bit of disease to that right coronary artery. It's not a big artery. And this is his left, so he's got a trifurcation of his left main. And that will be good to play again. But he's got disease. I should learn how to do this, Dylan. Which one is that? Is the internal mammaries. So it just doesn't get coronary artery disease like the other arteries do, so it's kind of spared. So the surgeon has to take this artery off the chest wall, tie off or clip off all the branches that come off it, because it gives off intercostal branches to all the ribs. And then they swing that onto the artery, and they always put it on the LAD, hopefully, or the most important artery that's involved, because they go for a long time. We used to do, we still do use them, saphenous vein grafts. And so you take a vein out of their leg, and they're pretty good for a while, but because they're a vein and they've got arterial pressure, they degenerate. So, you know, 10 years down the track, often they're blocked off, or they start to block off. And the other graft we often use is a radial artery, so we take that out of the arm, and that just gets sewn on, make a little hole in the aorta, sewn on distally. This is what the cardiothoracic surgeons do, not a cardiologist like me. And you can see this is a right internal mammary artery, so they do the same thing. So we used to, there was a sort of a big trend to use bilateral internal mammary arteries, particularly for diabetic patients, but the problem was they often got sort of ischemic infections of their sternal wound. So if you're not a diabetic, there's a bit of a, you know, they're doing more of these, what we call beamers or bilateral internal mammary artery grafts. And then you can also graft your radial artery onto the internal mammary. So this is one of my colleagues' dads, who was happy for me to show this. So he's got a lemur, so you can see it comes off the left subclavian artery, and it's come down, and that's anastomosed to his LAD. But then they've also sewn the radial artery graft onto the lemur, and that's swung around the back of the heart to go onto the circumflex, and then it actually goes on around to the PDA. So that's about, we had a funny episode of chest pain about 5 years down the track. So we did a CT and it all looked great. So this guy, things have changed in the last 3.5 years. So he's now got a critical narrowing of his left main, and you can see that supplies his circumflex, and then the LAD and the intermediate are now no longer thinning off the left main, but he has had bypass surgery, so that's just showing the before and after. That's 3 years ago. See what happens if you keep smoking and taking meth. The right coronary looks much the same. This is his right internal mammary artery, so coming off the right subclavian, and that's going down to his intermediate. So it's a good graft. He's got a bit of disease in that intermediate, but it's open. This is his lemur. And so you can see just after the anastomosis, there's a critical narrowing in the native LAD that wasn't there before. So we can go down that internal mammary artery. So if the LAD is open, you know, if there was a severe stenosis, you might fix up the LAD, but because that's totally occluded, we go down the internal mammary artery, put the wire right down, gives a bit of extra support, balloon that. So, you know, the angioplasty, we just do everything, we put these wires down, and we slide these balloons and stents that have a sort of a monorail segment at the end of them, down, and looks good, looks a little bit smaller, so we post-dilate it, make it bigger, and then looks good. Then it's got to fix up his native circ as well, and it's been diseased for a while, so you can see when we put the stent in there how there's a waist in it, how it didn't fully expand, so there's still a waist there, so we have to need a little step further down as well. This is the IVUS catheter, just to have a look and see how it looks. Actually, the IVUS, the thing that pulled it back was broken, so I just manually pulled it back rather than do sort of the 1 millimetre per second normal setting. But I tried to trim this bit. You see up here, see there how it's all black around it? So that's all calcium. So where that narrowing was, it's all calcified there. So that's why that didn't come up. So anyway, there are different options we can do to fix it up, but basically just blast it with a really big balloon and then get it to open up. So he's fully revascularised. So I'll just show one more case. This is just to show a bit of, some of the technologies that we have and what we can do. This guy is a 61-year-old offshore mechanic. Comes into hospital, he's had 6 hours of someone sitting on his chest feeling. He's had hypertension. His wife was with him and she said 3 times he just sort of passed out, hit the floor and then woke up again. He's got a laceration on his head, facial lac, sorry. He doesn't have any focal neurology. He is hypotensive. He is acidotic. He's got a raised lactate. He's looking pretty sick. They called me. They were going to put him through the CT scanner for his head. I said, let's just get him to the Cathlab. We need to open his artery up because he's really sick. This is his ECG. What do you reckon? Anyone worried? It's a bit ugly, isn't it? So he's got ST elevation, wide QRS, right bundle branch drop. All looks a bit yuck in his anterior wall. The inferior leads here. It's got marked ST depression. It's looking more ischemic. So it comes to the lab. Right's blocked. You see that it fills, and you can see how it fills late. And you can see how there are all these little sort of branches that come down distally. So this is what we call a CTO, a chronic occlusion. So he's never had chest pain before, but he's blocked this off sometime. But you know that his inferior wall is either infarcted or ischemic, not getting enough blood. And this is his left main and LAD, and the LAD is blocked, and his circumflex is open. So he's got a proximal LAD occlusion, and then presumably some of the blood from that LAD was supplying his inferior wall, and that's why he's so sick. So you can see there, stump occlusion. So he's got a balloon. See this thing here? I talked about the balloon pumps. You can see this thing pulsing to the side there. So he's got this balloon pump in his aorta just to give him some extra perfusion pressure of his coronary arteries and diastole. Because, before we start the case, you often make patients worse when you're injecting dye, when you open their arteries up. So you sort of want to, if they're really sick, you want to give them some extra support. And we opened it up, looked good. I actually went on leave. That was a Sunday morning, and I worked till Monday morning, and then I had a week off for Christmas. And while I was away for that week, he was actually pretty sick. He was in ICU. He had ongoing inotrope requirements. His troponin went to 400,000. When you turn up a bit late, and even when we open the artery, he still had a big heart attack. He's on dialysis. Had severe LV dysfunction, but he's also got severe mitral regurgitation, and I'll show you another slide of that later. So he got taken to the Cathlab actually on a Sunday night, and first of all we looked at his coronaries, and you can see the stents all widely open, And you can also see that the right coronary is filling from his LAD, so that was part of the reason that he was so sick. But, so he's still intubated, did a toe, and you can see this is his mitral valve. And every time it closes, there's this huge jet of regurgitation. So he's got torrential mitral regurgitation. And you can see that his leaflets just don't even meet. And there's a gap there. So he's got functional mitral regurgitation. So it's a bit of a tricky, case. You've got someone who's super sick, severe mitral regurgitation. What do? I guess you're sort of stuffed, right? You've got to do something because they're not getting better. Do you take him to surgery and do a mitral valve replacement? Going through coronary artery bypass grafting is a big shock to your body. So your prognosis is really bad. So this is a 3D of his mitral valve. So you see the anterior mitral leaflet and the posterior leaflet. There's this big gap where the leaflets just fail to meet. And that's the colour flow coming out of that hole every time the heart beats going back into the left atrium. This is a mitral clip, so it's a device, percutaneous. You go into the femoral vein, go up to the heart, you puncture across the interatrial septum, dilate a little hole in that, and then you steer this device, and you have this little clip. And so you're going to try and capture the mitral valve into the clip there. So you can see on this one, since B up the top, the device is open, you've got those two little thin bits. So they're grippers and they come down and clamp onto your mitral valve. So you've got to try and capture the mitral valve. It's a bit tricky when the mitral valve's far apart, and it's also a bit tricky when the heart's beating too, because you've got to catch it while it's open and closing. So this is all in fast motion. So you've done the septal puncture, you've got this great big tube through the septum. Then you put this even bigger tube up. So I think it's 20 gauge, so that's pretty big. And then you have this device that you can bend and reposition, and you can see there's a toe probe down there. And really it's the doctor that runs the toe probe that's sort of in charge. They're sort of telling you where it's got to be, which bits you've got to clip, which bits you've got to pull together to stop the leak. So here's the device through the mitral valve. So it's positioned, and you try and position it right where that regurgitant jet is. And then you see here, it's the same view. I don't know whether it's, I've got a shot of the grippers coming down. No, I didn't, you just can't see it because the frame rate's low. But basically they've trapped the mitral valve, and you actually pull the leaflets together, and you can see this is the device there pulling the anterior leaflet and the posterior leaflet together at that point. So you're making sort of a two lumen mitral valve when it's open, and his mitral regurgitation was much better. Anyone got any questions? What time is it? What is it? Oh yeah, that's an hour. Next speaker, right? Okay, I'm done. I don't need to show another case.
Let's hear it from Matthew.
Thanks.
Thank you very much, Matthew. Let's take 5 minutes. Before you do, you probably realised by now that we really like QR codes, because there's some new QR codes in front of you on the desks. They're just our feedback forms. So Dylan and I would love to hear from you. Any suggestions that you have for our conferences moving forward. Let us know what you liked, didn't like, how we can improve, because we really do love